overdose reporting system. And I'll move on to slide 2. What I want to let you know is that you don't need to take notes this morning. I have quite a a packed agenda for you today. My goal for today is just to give you a big overview of what the two systems do. And if you walk away knowing that if I contact these people when I need foundational information related to preventable violent deaths, we have a win. Okay, so and then you can go back and look at the slides later because Indira is going to send them to you, so you will have everything that you need. So just think of your questions as we go through this and relax because everything is written down. So the Illinois Violent Death Reporting System and the statewide unintentional drug overdose reporting system are, I'm going to read off this a little bit, are the only public health data sets that links information about who, what, where, when, and how with why these preventable violent deaths occurred. And our purpose is, our goal at our team, we collect the data and we disseminate it. We get it out to lots of different groups doing different kinds of prevention work across the state of Illinois. What you should also know is our data is also sent up to it's also actually when our data is put into the system, it is into these two databases. The databases reside at the CDC's headquarters in Atlanta. So we are working directly with the CDC on these systems. The Illinois Violent Death Reporting System collects data on, so we have one massive database, and we have 2 data sets within that database, IVDRS and SUDORS. IVDRS, the Illinois Violent Death Reporting System, tracks data on homicides, suicides, unintentional firearm injury deaths, legal intervention, and deaths that are of undetermined intent. We really can't classify them. Sometimes as overdose deaths, or we can't say that there was neglect involved or by a family member. There's a very high levels of surety with that kind of information. So we really can't tell specifically, we will put that information into undetermined intent. So our data comes from the Illinois Department of Public Health Division of Vital Records. So every 3 months we go out there and we collect data that is coded a certain way, basically preventable violent deaths. The data that we collect has been assembled by the coroners and medical examiners' offices, which comes from death certificates, funeral directors, and toxicology reports, police reports, even newspaper reports. So we collect all of that data, and also the coroners will oftentimes provide a narrative for us. So our team collects all of that data and puts it together in one spot and in one record, and we call that a case, individual cases. The cases are anonymous, and our goal with collecting that data is to look at trends and patterns over time. We're funded by the CDC, and we're considered an agent of the Illinois Department of Public Health. So the Illinois Violent Death Reporting System, that one section, we report out that data every 2 years. So and with the SUDORS data, we report out every 18 months. And you might say, oh, that takes a long time to get that data together. And it does, because the data are considered legal documents. And so it has to go through quite an extensive process before we can deliver it to you so that you can use it in your injury prevention work in your community. And the work has, and I'll go into this a little bit later, this work is really for looking at trends and patterns so that you can do those deep dives, so you can do institutional level work and to see your progress over time. And so it's a little bit different than work. Oftentimes when people say, well, I need to know what corner I can go and stand on today and hand out NARCOM. That's not what we're about. This is a different kind of work that we do. Some of the, of course, we're dealing with databases, and you're just think of a giant Excel spreadsheet with all those variables, right? And we have about 2,400 variables in those spreadsheet divided into those two sections. And so that's what we're pulling data from. Now, the problem with the data is that because, you know, the circumstances that we're gathering the data within can be, you know, obviously very traumatic. So when we're gathering data from the funeral directors, you know, we may not get all the information that we need. We get a lot, but may not get everything that we need. And so there can be some flaws, not flaws, but there can be some gaps in our data, or missingness, we call it, in our data. But the overall trends are pretty good, are good. So what we do is we look at the incident types, which I've told you what those are. This is within the Illinois Violent Death Reporting System. And we can look at the type of weapons that are involved, and the circumstance and demographic information around that can be very helpful for prevention work. The other variables that people look at a lot are recent release, or any interaction with a system of any kind, because if people interact with a system prior to, you know, a fatal, or, you know, a death, we may be able to get information to those providers so that they can give out information to prevent deaths in the future. Here are some of the data around homicides that are, or sorry, variables around homicides that are people look at a lot. Mental illness, recent release, and recently we've been getting a lot of requests on intimate partner violence, because it's being seen as a major driver of violence in communities. We've done a lot of very innovative work around that. And that innovation comes out of actually working deeply within the community, asking questions. And I think what's really neat about our team is that even though we're working with big data, we make just huge effort to bring it down to the community level, engage with people. And I'm going to talk to you a little bit about that later, on how we do that and how it gets people really thinking about their community and the resources they have in their community, and how they can use our data as a foundation to help them do their good work. So the state unintentional drug overdose system, which is kind of our primary focus today, though I'm showing you everything so that you have it, because I know you guys are involved in many different you know, aspects of prevention. So I want to make sure you know both aspects of our system. Again, we have a lot of the same types of demographic information, a lot of circumstantial information, but we also have the toxicology as well here for the overdose deaths. And again, some of the variables that we have available. The other thing that I'd like to point out is that we also have a data dictionary of all the variables, and I have a link to that data dictionary so that you can look at data dictionary, the variables and how we define them. We found that working with community groups, sometimes when you're working with people that haven't done this kind of work before, they get into what does that mean? How do you define that? And there can be a lot of discussion around that. And so if you look at the data dictionaries that we have that can really help with that, they were put together by the Centers for Disease Control, and they are how they look at information, so that information is available to you in your community as well. And yeah, so all of these fields are defined, how our team puts the data in, what specifically they're looking for, can be really helpful. So how do we get involved with communities, and how do we start these community conversations? And the idea is that our data is foundational. We think it's foundational to starting these community conversations. So if you have the data and we pull it together, we can do age clustering of data. I'll show you some images of that later. Victim suspect relationships with IVDRS. we can do mapping of high, we do mapping of high density overdose deaths. We target by zip code and by block so that we can have intervention efforts. I can talk to you a little bit about some work we did on the west side of Chicago, where we identified some blocks that there were a high incidence of overdose deaths. And we have teams working, going door to door in those communities, dropping off information, getting information out to the community about resources. And again, here, moving away from event-based decision-making to trends, patterns, contributing factors, basically getting into that structural work, that space that we need to be in order to do, solve some of these entrenched problems that we have in our communities. Our work can strengthen grant applications. It's been used extensively in that way. It shows you year over year how your work is progressing, and the work. Some of our reports end up on the desks of, state representatives, state senators, and I'll show you some of the reporting that we've done around that in a little bit. And some of the work that we can do with you is we can do a little bit of one-on-one coaching, to show you how we present to groups. We like to stay in the background. We always like for you guys to lead, but we're here to provide with data and to show you how we work with communities and what's been where we've been successful in the past. A lot of our data is used to support workshops, community forums, and we work with lots of large groups. We have lots of large community partners and statewide organizations that use our data. And so here's a fun graphics that you can look at. So with the regional offices of health, the Illinois Department of Public Health, they have regional offices, and which are made up of counties, and we'll work at the county level, at the regional level. We work at the county level with them, and then at the street level where they need it. In Chicago, we work at the community level, and we also the Chicago is divided by what they call health equity zones. And we've been doing a lot of work on the west and near south and south sides in particular communities. And we've been doing heat maps like we've done in the Garfield Park neighborhoods, where we will show people where they can go and do outreach work. And here's an example of some of the work that we've done at the zip code level, showing homicides and suicides in particular neighborhoods, in particular zip codes. For our workshops, what we can do is we can pull together data for you on suicides for county, for community. We can go through the demographic and circumstantial information. One of the things that we did is on the west side of Chicago, they brought in, a community group brought in about 60 different other community groups. We went through the data. We asked them to highlight data that kind of, didn't look right to them, or, and so we had a lot of time, a lot of conversation, getting them used to working with the data and how to think about the data. And it was a very gentle approach, but, just tell us what you think. Tell us what numbers pop out for you. And because sometimes people see this data and they don't know how to react to it. So it was a really great way to get people to enter into it. And then we had breakout sessions and where we asked questions. The teams asked, various questions of the groups, and then they came back and they shared. And it was an incredible community conversation. And what came back was pretty jarring. And they realized that they needed to, change the way that they were doing some of their work. A lot of the, the grants that were available to them were, orienting them to work in one direction when they were noticed through the data and through their own perceptions, through their own lens, that their problems were actually in a different location. So the area of their community. So that was, it was a really interesting conversation. We do graphs like this this is also unintentional drug overdose deaths. This is a county-wide map that we do, or sorry, charts that we do. These are really helpful if you're going to speak to a state representative and you just want to, you want to give the big picture and kind of to ease them into the conversation. We stopped doing these kinds of reporting about a year ago, but we realized that people really like them, so we're bringing them back this year. Let's see. This is a different way of working with counties. This is the Illinois Department of Aging. They group the state up a little bit, the counties up a little bit differently for their work. They have been noticing that the amount of suicides have been going up among the older population, and the number of overdose deaths are going, I would say, skyrocketing in our older population. So we did a lot of reporting on that last year, and we are coming out with another report very soon on overdose deaths related to people 55 and over. So I'll get that to Indira and she can get it out to all of you guys. With domestic violence, we're moving over to the Illinois Violent Death Reporting System, and we've done some work recently where one community we worked in, again, we went in, they said they saw domestic violence as a driver change, and violence in their community. So we went and looked at some of the basic numbers, and we weren't seeing that. So we took a deeper dive into it, and we expanded. What we did was we looked at intimate partner problem and domestic violence as being a part of that. And when we looked at it that way, the numbers were shocking. And so that information ended up, that kind of thinking that the team did there ended up going to the domestic violence, the statewide domestic violence fatality review team. And they're taking a look at that way of looking at data, and you can connect to our data dashboard for the Illinois Violent Death Reporting System. Tons of information out there on that, and also on intimate partner problem and violence is also out there. So you can look at that data and actually run some reports of your own. But what I wanted to show you here is, it says analysis selection criteria, is you'll see how we actually our team went in and built the analysis out off of all those variables and pulled all that data together to create these reports that kind of shone a light on, it really was a driver of violence in communities, but it looked very different from the way they were used to thinking about it. And so sometimes with this data, when you go in and look, it can cause a lot of cognitive dissonance, if you will, a little bit of disorientation, because we're used to thinking we all have our biases, and the system will come back and kind of challenge us to think differently oftentimes. So examples of our work, we have a calendar. We try to get data out every few months. We try. We're not always successful because some of the data, it's public health, so the data has to be absolutely perfect. And sometimes we're looking at data in, very unique ways. And so sometimes it takes us a little while to get data out. We ask people to be patient with us, but the other thing that you can do is you can go look at examples on our work on our website, and we have some great reporting out over the years. But if you see the data there and you see some reports there and you say, oh, that's 4 years old, or that's 3 years old, don't worry about that. Come on back. We don't always, update those reports out on the website. We're just so busy. So we may already have an updated report on that, or we would be happy to update it for you. And, look at it in, some ways that are unique to your community. So that's okay too. This is a little bit more an intimate partner problem that I wanted to, we're so proud of that work. I have 2 slides on it. I probably shouldn't have that. But it gives you a little insight into how we think. and this might be helpful for you, the background, how we, whatever reporting that you want us to do for you, you'll see we look at, the background, we will talk to you about the methods that we use, and then the various variables that we're bringing together. So you have a really strong foundation when you go out and talk to the community about your work, and it creates that sense of ease and trust within the community when they understand your rationale. And gosh, I went through that very quickly. I know I'm on a lot of time constraints this morning, but if you want to get our newsletter, there's a live link. You can sign up for that. We're on LinkedIn. We have reports that we send out that way. You can get our, we also have a link to our IVDRS reports. So you need to scroll down to get to them. When you get to that link, scroll down, you'll get to see all the reports. Our unintentional drug overdose reports, our data dictionaries, the SUDORS dashboard. So there's a dashboard that you can go out to and take a look at that data there and play with it. We have a violent death reporting system dashboard and firearm dashboard. So we also have connections to costs of injury. Oftentimes when people are presenting to, various boards, they'll say, we can't do this because it's expensive, but they don't know that they're already paying for it. And so just some information here. The other thing I'd like to do right now is, because I'm coming to the end, and one of the things I realized I forgot to do, Indira, is to, there's a lot of overlap in our databases. And I know, Indira, you wanted to talk about that a little bit. I should have, I had a report to do, I had a note to myself to hand it over to you in slide 2, but here we are at the end.
You were on a roll.
I hope I didn't go too quickly, but I know I had time constraints.
No, you're fine. You're fine. I was going to give you a few extra minutes if you needed it. I
Okay.
just wanted to briefly talk about suicide fatality reviews because of, as Kathleen was saying, there's so much overlap between the two. Overdose fatality review teams and suicide fatality review teams often involve a lot of the same team members that are already built up if you have a team going. So the conversations are just sort of pivoted a little bit to include other topics involving suicide beyond just overdoses. And so the SUDORS data may be a little less useful there unless you're, but the IVDRS data is very, very useful. And so I just wanted to get Kathleen's take on, what kind of data can be taken from those databases and used to analyze individual cases for suicide deaths.
When it comes to the individual cases, that goes through the Illinois Department of Health. We do not hand out for the fatality review teams looking at individual cases, you would work through them for that data. For us, where we are seeing a lot of overlap, and the folks that on our team who work with suicide and suicide prevention see a lot of, we can't often identify as an overdose as a suicide, but we know that people are flirting. There's a lot of, it's an awful word, but they say flirting with overdose. And unless there is a note, we cannot say it's a suicide, but we know that a lot of our overdoses are suicide. So yeah. So as far as reporting is concerned, we can give you the numbers for a community. We can show you that and get that foundation for you so that you can look at individual cases. The other thing that we can do, that you can look at the reporting on it. We can give you narratives if you would like to see narratives, because they are not specific. So we can talk to you about that. The narratives, as you know, can be very jarring to look at. But if you request it, I can ask Mariana about that. So yeah. Where our data is mostly used is in looking at the patterns and the trends. The also one thing I didn't mention is that if there's any universities or groups that work with universities or colleges, the narratives, you can do a text search, word search, if you will, on the narratives. So you can come up with a cluster of words that you want to search on, and you can do that. The universities can do that. And the other thing that you may be interested in doing is going out to the CDC's website, where you can actually see how our data compares to other, because our data joins with the National Violent Death Reporting System, so you can see how Illinois compares to other states as well. Did I answer your question, Indira? Did I?
Oh, definitely.
Definitely?
Yes.
Okay.
Yes, definitely. But I just wanted to plug SFRs in case anybody was interested, because if you have a county with a low overdose rate and you don't think that having an OFR team is a worthwhile, use of your time and resources, having that combined with a suicide fatality review team can really increase the utility of that team's function. So if you're interested in looking what suicide fatality review teams can do, I did include a couple links to the SAMHSA website, where they provide technical assistance for people who want to start SFR teams in their communities. And there's also a link to the New York State toolkit for starting a suicide fatality review. So I will include those links as well in the follow-up email to this meeting.
And Dira, if I could also mention one thing,
Sure.
oftentimes, when people are thinking, oh, talking to Northwestern, this is big data, the CDC, and all that kind of thing, they might think, oh, I have to show up and with a perfectly formed question or thesis. We do a lot of thinking with our partners, so we're happy to think with you about if you think, I'm looking at information this way and this way, but I'm not really quite sure how we want to pull this together. Have you ever heard of this or seen this? We can work with you, and some of our best work comes out of those collaborations. So don't feel that you have to have everything perfect to come and work with us.
It's an excellent point. So if somebody wanted to request a report from you guys, who is the point of contact, or is there a link that they can click?
Yes, you can get in touch with me directly. My name and contact information is there. And out on our website, there is a form that you can fill in. What I'll do, I'll go find that, and we can can send that out to the group. There's a form for requesting information as well. Just email us at any time, and we'll get back to you. We're happy to. That's why we exist, is to get back to you.